All right, good morning, everybody. Thanks for joining us for the role of the fire officer and firefighter behavioral health webinar this morning with Captain Brandon Dreiman of the Indianapolis Fire Department. Today's webinar is sponsored by VFIS, and so I have a brief video to show before we turn it over. So let me just get this flipped over real quick. And here we go.
VFIS is the largest provider of insurance to fire and emergency services organizations in the country. Founded in 1969, VFIS quickly became the gold standard in coverage, training, and risk management for the industry. And our associates don't just specialize in fire and emergency services. Many of them live it, serving as firefighters, chiefs, EMTs, dispatchers, rescue squad members, and more.
We have the ability to make firefighters, their families, or their departments whole, and hopefully take some of the worry and stress off of them, that whatever has occurred, that we can make it right for them.
I was fortunate enough to have the opportunity to travel to a client's fire station and step inside and speak to the clients themselves. That was a life-changing experience for me, and it really woke me up to why I do what I do and who I'm doing it for, and it made a world of difference to see that these are the faces of who we are supporting and who we are providing products to, and the faces that we are making a difference in these people's lives, and these people are making a difference in so many lives.
I've been at Gladfelders for 35 years, and the reason that I stay at Gladfelders is because of the people that are there, the senior management that believes in all of us, and also that we get to serve the emergency organization, and we get to pay it forward. And at the end of the day, we make an impact on people's lives.
All right, and Captain Dreiman, it's up to you now.
All right, thank you. Thank you for that introduction, and thank you to VFIS for sponsoring this event. Let me get my screen up here. Okay. Again, good morning, everybody. My name is Brandon Dreiman. I'm a captain with the Indianapolis Fire Department. I am our coordinator of firefighter wellness and support. So I oversee our peer support program, cancer support, our chaplain program, and our mentorship program. So pretty broad reaching. I, in particular, I guess specialize in addiction services. Our goal with our unit is to help any firefighter or anyone living in their family to access behavioral health or addiction treatment services. So we kind of serve as that bridge between the firefighter and the family and whatever services are out there. And today I'm just going to go through some slides and talk to you a little bit about the role that fire officers can play in the behavioral health of not just themselves, but also of their crews. We have a few goals to lay out here. The first thing is we're going to define what a behavioral health disorder is. There are a lot of different definitions of behavioral health disorder. You may have your own definition, and that's perfectly fine. But I feel for the purposes of this discussion, being on the same page, at least as far as what we mean by that term today for this hour is useful. So we'll kind of lay out what we mean by behavioral health disorder when I use that term. We're going to look at some very common behavioral health problems. These are some that we see more frequently come through our office, and I think that probably nationwide, these are issues that are pretty common in the fire service. I don't want this to be a signs and symptoms discussion. That's, you know, we're all medical professionals. We can look up the signs and symptoms of these disorders. But I do want to be able to give you some concrete take-home points about each of these topics so that you can begin to use them. How can I utilize these to help my crew out, that type of thing. So we will talk about some signs and symptoms, but that's not the focus of this presentation. It's really on what concrete take-home points I can give you for each of these issues. We're going to talk about suicide. And then we're also going to talk about self-care and the role that you can play in encouraging the members of your crews to engage in good self-care. And that starts with you. As a leader, one of the things that we can certainly do is model good behavior. So this is an opportunity for you to look at the 6 ways that you can improve your own self-care and then also improve the self-care of your crews. So behavioral health disorder, what is it? What does it mean when we use that term today? Really what we're talking about is a behavioral, psychological, or emotional problem that is getting in the way of a person's life. And it's that last part that's really, really important to kind of focus on, that whole getting in the way of someone's life. We all sometimes wake up depressed. We all grieve. We all wake up angry. These are normal human emotions. They're healthy human emotions. They're things that we need to feel to process different events in our lives. However, normally those emotions don't get in the way of our life. But if you're sad enough that it's beginning to impact work, or if you wake up angry enough of the time where you're going into work, or it's showing up at home and it's starting to impact your day-to-day life, then yeah, that's when we are concerned that maybe there's some type of disorder, some type of treatment may be needed. We don't want to be over-inclusive though. We don't want to say just because you've been sad for a couple of days that we need to get you in to see a behavioral health professional. That can tend to scare people away, and that can somewhat add to the problems. So until it starts getting in the way of a person's life, our office usually doesn't worry about it. I will say though, if you're working one of your crew members and you notice that they are acting angry, or they're isolating themselves from crew, if you're noticing at work, it probably is impacting their work. So keep that in mind as you look at your crew members. If you're noticing these changes in attitude or behavior enough that you've picked up on it at work, it probably is having some impact and maybe worth having a discussion. But we'll get into some particulars of that in just a little bit. We all recognize that firefighters are not very good at seeking out treatment. There are certainly a number of reasons for that. The number one reason is stigma. I don't think that probably surprises anyone in the audience. If your agencies are anything like mine, once you receive a label, you may never get rid of it. And that's a legitimate concern. There was a survey done by the Warriors Research Institute out of Waco, Texas, and they surveyed over 2,000 firefighters and asked them whether or not they would get help if they had a behavioral health problem, and if they would not get help, why not? And 92% of those firefighters responded that they would not get help because they would be afraid of the stigma. They would be embarrassed, they would be labeled, they would appear weak, they would appear like they couldn't fix their own problems. All the things that we already know are confirmed across the United States. And it's not just stigma. There are some very concrete reasons also why people don't seek out treatment. One, they may not know what resources are available in their area. And because of that, they're not about to ask anybody because they're afraid of the stigma. So stigma plays in with that as well, but they may not know what's available. Depending on the area, depending on local resources, there may not be anything available. Your local emergency department may be your one-stop shop for physical and emotional health. And that can certainly be a barrier when we take patients to that emergency department and our firefighters know nursing staff and the physicians and things like that. They may be very reluctant, and somewhat understandably so, to go to that emergency department for help. We also have issues with insurance. Some people, I know I have high deductible. I'm going to be $5,000 out of pocket before my insurance even kicks in. That's a tremendous obstacle for somebody looking for behavioral health care. Sick time. If you're a career firefighter, what kind of sick policy do you have? If you're not a career firefighter, say you're a volunteer and your main job is farming or plumbing or whatever it may be, you may not have, if you're own your own business, you may not be able to just take off work to go get help. So there are some very concrete barriers that can keep people from getting the help that they need. But stigma is by far the largest that we hear about. I always just like to ask people to think a little bit about some common behavioral health problems that pop into their mind. And I'm going to put a list up here, and probably some of the things that you're thinking of now are in this list. And these are the things that we're going to look at and hopefully give you some concrete information about. These are the things that we see most commonly come through our office. Anxiety is also very common, but I had to draw the line somewhere as far as what we could discuss. And since we also discuss PTSD, which used to be classified as an anxiety disorder, I just kind of kept that, but excluded anxiety more generally from the discussion. But that is certainly an issue that we see. And I also recognize that suicide is not a behavioral health disorder. It's the culmination oftentimes of behavioral health problems, not always, but frequently that's the case. So because it's so closely linked to behavioral health diagnosis, I went ahead and included it under here, but I do recognize that it's not a behavioral health problem in itself. So let's start with alcohol use disorder. And the first question that I like to ask is, does a person have to be an alcoholic to have a drinking problem? And I would encourage you to answer that yourselves. Do you think that somebody has to be an alcoholic to have an alcohol problem? And most people intuitively think no, that it shouldn't be necessary that somebody be an alcoholic to have an alcohol problem. And I think if we think of some examples of that, perhaps somebody who may not be dependent on alcohol, but who every time they drink gets blackout drunk and drives their car, even if that's 3 or 4 times a year, that's a problem. That person may not classify as addicted, but that, I think we would all agree, is an alcohol problem. When addiction medicine people look at addiction nowadays, they don't even look at alcoholic versus non-alcoholic or addict versus non-addict. Instead, they look at a spectrum. Looking particularly at alcohol, they look at alcohol use disorder. And it is a spectrum because they recognize that very large alcohol problems start out small. So you'll have a small drinking problem that grows over time, it progresses, it becomes chronic, and then you have major issues as a result of that. So we don't just look at whether or not somebody is an alcoholic or not an alcoholic. We look at where they fall on that alcohol use disorder spectrum. You see some questions up on the screen, and there are 11 questions associated with an alcohol use disorder diagnosis. I don't read many slides, but I am going to read these next 2 because this is such a pervasive problem in the fire service, both career and volunteer. Our use of alcohol and abuse of alcohol is pretty tremendous. So I want you to think about, as you answer these questions, not just you, but maybe your crew members as well, and whether or not you think a crew member may have an issue with alcohol. And if so, how many of these questions they may be able to answer yes to. And the way that this works is a clinician will read through these questions, and for every question that you can answer yes, you would give yourself a point. And at the end of the 11 questions, you add up your total points, and that will tell you whether or not you're on the scale for alcohol use disorder and then where you fall on the scale. So it's really super straightforward. So I'm going to go ahead and do this and answer these questions for yourself or for the members of your crew that you're concerned about. In the last 12 months, have you had times when you ended up drinking more or longer than you intended? More than once wanted to cut down or stop but couldn't? Spent an excessive amount of time drinking alcohol? Wanted to drink so badly you couldn't think of anything else? Found that drinking interfered with major obligations like work or family? Continued to drink even though it was causing trouble with your relationships? Cut back on hobbies or fun activities so that you could drink? More than once got in situations where drinking jeopardized your safety? Continue drinking despite depression, blackouts, or other health problems? Need to drink more than before to get the same effect? And when unable to drink, you have withdrawal symptoms, for example, the shakes, nausea, and sweating. So you should have a total for yourself or for your crew members that may have popped into your mind. And just consider for a minute how many points you think you would need to have before you landed on the scale for alcohol use disorder. The 2 most common answers I get are 1 and 5, and the actual answer is 2. 2 to 3 of those symptoms in the last year would classify as mild alcohol use disorder. And that probably sounds like a lot of the firefighters you know, and statistically, you're probably right. We do see a tremendous amount of alcohol use disorder in the fire service. That's why I spend a little extra time on this section here, and we will see alcohol use disorder come up a couple other places in this presentation because it is so problematic. And I speak to you from experience. I was a 9 out of 11 for a long time. I suffered from severe alcohol use disorder. That's how I got involved in behavioral health programming. I ended up, came in and got pulled for a random drug screen one morning when I came in for shift. I felt fine. I joked with the crew on the way out the door about having to go get tested. And I got to the testing center and I blew positive for alcohol. I had had so much to drink the night before and my tolerance levels were so high that I still had alcohol left over in my system. I was suspended. Fortunately, we have a really good employee assistance program here. I was able to get sober over 8 years ago, and that's how I got involved in this. And from that have come some really tremendous opportunities. Our behavioral health program in Indianapolis has grown. I went to yoga teacher training and teach yoga now for firefighters, teach for the IAFF. A number of really good things have come from getting sober. And I don't bring those things up to pat myself on the back or say, look what I've done. I bring that up to say that I went from a guy who couldn't be trusted with an open liquor cabinet to the coordinator of wellness and support for the 10th biggest fire department in the United States. So recovery is possible, and you will see my contact information at the end of this. If you are concerned about yourself or a crew member, my offer to you is that you reach out to me. Call me, text me, let me know your concerns, and I'll talk to you about them. It's that important to me to help people get sober because this is such a tremendous problem. So please take advantage of that, because I'm proof that people do recover every day. And I'll help you find the resources that you're looking for. So please keep that in mind. Also, keep in mind that oftentimes behavioral health problems don't happen in isolation. And that's what we see a lot of times with firefighters is we will see that firefighter who drinks too much, but the question isn't so much, that a person is drinking, it's why are they drinking? What is driving that need to escape? And we will frequently see that firefighters will have depression or anxiety or PTSD or some other behavioral health problem underlying that urge to escape, underlying that urge to get away from the pain. So in my case, it was some anxiety disorder problems that I had, and that's why I was drinking, to try and go to sleep. So you can see from the stats, depression is a big issue in the fire service, particularly among female firefighters. Sleep disturbances, it's not a big shock that firefighters have sleep issues, and we will look at sleep deprivation in particular in some coming slides. But just keep in mind that if you are talking to a firefighter about getting help, we always refer people to what are called dual diagnosis facilities, and that means a treatment center that can handle both addiction as well as mental health problems. Under evidence-based treatments, we know that people who are treated for both of those issues at the same time fare a lot better than people who are treated for, say, an addiction. They go through that treatment process, they're discharged, and then they get treatment for depression, or vice versa. If they can be treated together, the patient fares a whole lot better. So that's just something to keep in mind is if you have a talk with a crew member about getting some help, or if you're looking for help yourself. Sometimes people aren't willing to get help for themselves, and they can be motivated to get that help for their family members. And as officers, I would encourage you to keep this in mind, that if you have a crew member who you suspect has an alcohol or drug problem, that if they have family at home, I guarantee you their family members are also suffering from this. Family members are left to pick up the pieces. They're left to be the responsible parties. They have to deal with the sickness and everything that goes along with having a parent or a partner who is an addict. So when talking to your crew member, this can also be something to bring up, that what do you think your kids would want? Would they want you to go on like this? And how do you think this is impacting your children? And if you're not going to do it for yourself, maybe consider getting sober for your kids or for your spouse, because I guarantee you that they are also suffering. This disease does not just happen in isolation. The take-home point for alcohol use disorder is that you do not have to be an alcoholic to have an alcohol problem. And I hope that this discussion has made that clear if you had any question about it. The next topic is depression. When we think of a depressed person, we tend to think of someone who is sad, isolated, down in the dumps, so to speak. Clinically, that is what a clinician's going to look for. Somebody who is sad all day, every day for a period of 2 weeks or more. This is going to have an impact on their life, both at home and at work. The trick with us, though, is that firefighters tend not to present sad. They tend not to present crying. We tend to present angry. When we are vulnerable or threatened, it triggers a fight or flight response. And as firefighters, we don't fly. We don't run from danger or confrontation. We get into it. We fight. So it's not surprising that when firefighters are suffering from things like depression, they feel vulnerable, like they're out of control, like they're weak, that they posture and their response is to become very angry. And when we look at symptoms of depression, there are a lot of them, but the one that I really want you to focus on is irritability. And this is going to be across the board, not just for depression, but for any behavioral health problem that firefighters suffer from. We tend to see anger and irritability at the top of the symptom list. So keep that in mind with yourself, and in particular with your crews, that you're going to see a lot of anger and irritability in people who are starting to suffer from behavioral health issues. Depression is very treatable. There are two prongs, though, to effective evidence-based treatment for depression. The first is medication. There are a lot of really great medications out there. The second prong of treatment is some type of psychotherapy, where you sit down with the social worker or with the psychologist and talk out your problems, discuss some behavioral therapy methods, any number of other things. But we tend to have a breakdown in this process. What we see is a lot of times someone will start to feel depressed, so they'll go to their physician. They make an appointment with their physician to talk to their doctor about it, see if they can get on some medication. Unfortunately, and things are getting better, but unfortunately, traditionally, physicians have not been great about referring that patient out to behavioral health treatment. I went and sought treatment originally for anxiety, was put on medication, but was never referred out to a psychotherapist or any type of therapy for my anxiety. The same thing tends to happen with depression. So what happens is the person will start their medication, and if they make it through the side effects, which is a whole other issue, particularly with drugs like Effexor, and these all have side effects, particularly the first 2 weeks to a month as your brain gets the new chemicals on board, that can be really hard to deal with. But assuming the person makes it through the side effect stage, they'll get better for a little while, and then they'll kind of stagnate without that psychotherapy. So as a result, they're like, I'm just not getting anywhere. So they just quit taking their meds, and then they never try again, because that's how we are. You get one bite at the apple with us. So that's very problematic. I encourage people, if they're going to talk to a medical professional about depression, to make an appointment with a nurse practitioner if they can. Nurse practitioners receive more education on behavioral health than physicians do. So they're a good option to talk to about this. But the key really is this two-prong approach of medication and psychotherapy. A lot of people after six to 9 months or a year are able to wean off the medication and stop going to therapy. This is really designed to kind of reset things. Some people are on medications long-term, but a lot of people are able to come off of them. So it is highly treatable. Initially starting out, it can be a little tough with side effects, but if you can make it through that, it's well worth the effort, because people frequently get a lot better from depression. The take-home point, though, is across the board, if you notice that a firefighter in your crew is suddenly a lot more angry, a lot more irritable, that should raise red flags for you that maybe you need to have a conversation with that person about what's going on. And just stay in your lane. You don't need to diagnose whether or not it's depression or anxiety or anything else. Your job is to notice that change in attitude or that change in behavior and ask the person about it and see if maybe it's something they need to explore with a clinician. Post-traumatic stress disorder, very hot topic, so to speak. We are exposed to traumatic event after traumatic event. All of that trauma goes in a certain area of the brain where it's processed. And if it's not properly processed, it starts to add up. It never gets filed away appropriately. And if you think of that area of the brain where this all goes as a cup, it'll start filling up, filling up, filling up. And if it's not processed appropriately, eventually that cup will run over. That trauma has nowhere else to go. So it spills into areas of the brain where it's not supposed to be. And it results in some symptoms and signs, and ultimately can result in PTSD. If we look at some prevalence numbers, these are lifetime prevalence, not annual prevalence, but in the civilian population in the US and Canada, about 8.5% over the course of a lifetime will suffer from PTSD. Veterans are 11 to 20%. The fire service is at least 20%. Law enforcement is also at least 20%. And then EMS is at least 30%. So what may account for some of those elevated numbers that we see in first responders? And I think there are a number of answers. You probably have some in mind. One is, I know in Indianapolis, a lot of veterans come to work for the police department, the fire department, and for Indianapolis EMS. So we have some people who are coming to the job and perhaps have some trauma already filling up their cup before they ever are sworn in as firefighters. So as a result, they're coming in with trauma that hasn't been processed. Some of them may actually have PTSD when they take the job and just don't know it yet. So that is one issue. Another issue is people with, there's a test called adverse childhood experiences where you look at somebody's trauma from childhood and whether or not it's been dealt with appropriately. And it tells you some things about how that person will develop psychologically. And one of the things that we know is people with high adverse childhood experience scores, they're drawn to work where they can help other people and where they can be in control. So it's not surprising that people who have that history are drawn to work as first responders. So a fair number of people involved in this business are coming to the table with some childhood trauma that's probably never been discussed or addressed in any way. And that can also lead to higher PTSD numbers. And then finally, just that cumulative effect. I look at an engine here in Indianapolis, one of our slower engines. We have, like most cities, slow engines and fast engines and everything in between. And I know that is somewhat of a relative term, fast versus slow, but a slow engine here will do 1,000 runs a month. So if you do 20 years on that, doing a third of those calls a year, so 300 runs a year over 20 years, that's 6,000 calls that firefighter's responding to. How many of those are significantly traumatic? And over a 20-year period, a lot of those are going to be traumatic. So we just have a real cumulative effect to this that sets us up for having problems. In fact, when you think about it, we're actually pretty tremendously resilient that we don't have more problems than just 20% of us in the fire service having PTSD. That shows how good our social support systems are and the way that we're able to process this trauma, but it's still an issue that we have to face. These are some of the signs and symptoms of PTSD. This list is not exhaustive. There are a lot more in each of these categories. But this kind of gives you an idea of what a clinician is going to be looking at and talking to somebody about as they look at these different categories of symptoms. One of the things we have to consider, though, is if we look under re-experiencing, you see bad dreams under there. And I've had nightmares about bad calls. Probably everyone in this webinar has had at least one nightmare about a bad call. Avoiding places or events or objects that remind you of a run you've been on. Before I joined Indianapolis, I was a volunteer for 10 years, and one of my high school friends was hit by a train. And I went on that call, and I distinctly remember avoiding that train track crossing for quite a while because I didn't want to be reminded of what I saw that day. Under arousal and reactivity symptoms, we see being easily startled. We probably all know a firefighter, or we personally have been that firefighter who somebody will drop a spoon in the kitchen and we just about shoot through the ceiling because it startles us so bad. We just see a startle response out of proportion to the stimulus. And that's happened to me. And then finally, feelings like guilt or blame. I've come off of calls and completely unrealistically blamed myself and felt guilty for the outcome of a call that I couldn't change, but I still felt that guilt and that blame. And I would assume that as I went through these, probably a lot of you who have tuned in here today have had similar experiences. And does that mean that we have all had PTSD? And the answer is no. We have to differentiate between post-traumatic stress and post-traumatic stress disorder. On some level, because we're exposed to so much traumatic stress over the course of our careers, we're all going to have some symptoms at some point of post-traumatic stress, whether it's that heightened startle response or wanting to avoid reminders of an event, whatever it may be, that's going to impact all of us on some level. So what's the difference in between post-traumatic stress and post-traumatic stress disorder? One thing is when we look at the symptoms that are present, in order to have PTSD, you have to have a certain number of symptoms from each of those categories for a diagnosis to occur. So if you just have one symptom from each of those categories, even if it's long-term, it's not going to be enough to qualify as PTSD. There's very particular criteria that you have to have a certain number of symptoms from each of those categories. And then second, there is a time element involved. You have to have those symptoms for a period of 30 days or more for a diagnosis to occur. So we have a 1-month period of a certain number of symptoms for a diagnosis of PTSD. And that leads us to the take-home point. If you or a member of your crew is exhibiting any of the symptoms that we've discussed here, sorry, I hit my keyboard there. Any of the symptoms that we've discussed as far as PTSD or depression, anything like that, if they have symptoms for a period of 2 weeks, that's when we need to talk to them about getting a professional consultation. That's relevant for a diagnosis of depression. It's also really helpful with PTSD that we're giving people time to process trauma, but we're not waiting a full 30 days before we try and get them help. If we can get them in before that 30-day period is up, it makes it much easier for a clinician to treat them and get them in to a better outcome. So again, staying in our lane, we don't have to diagnose PTSD or depression or anxiety or alcohol use disorder, any of that stuff. But if we notice that a member of our crew is exhibiting symptoms for a couple of weeks, we need to talk to them Even though it's a difficult conversation, we need to have that conversation about them reaching out and getting some help. So 2 weeks is a key marker there. We'll take a quick look at compassion fatigue as well. This is now known as vicarious trauma, which I think is a good change. The name compassion fatigue just, I think, softens it too much. Sounds more like you need a nap just because you're a little worn out. But compassion fatigue runs a lot deeper than that. What happens with compassion fatigue is you're exposed to other people's trauma. There's stories about it, that type of thing. I may not go on a fire that involves 4 dead children, but I may hear your story about that same fire, and I can be impacted by that. And because our brain processes all that trauma the same way, even if I haven't personally experienced it, if I hear you describing the trauma, it can have the exact same impact on me as if I had been there myself. So we see the same signs and symptoms and diagnostic criteria that we see with PTSD. It manifests itself the same way. Our brain does not differentiate between trauma from a story that we hear through our ears and actually visualizing trauma through our eyes. If it picks it up, it's going to see trauma as trauma. And if it's not appropriately processed, then it can cause us problems just like PTSD. Not surprisingly, the major signs of compassion fatigue are anger and irritability. Again, across the board, that is a really big red flag that our people are struggling. Sudden anger and irritability. Another problem is cynicism. And I'm sure that we all know cynics on the job as well. And what we mean by cynicism is some people will start to personalize calls. Like they're under the impression that somebody calls 911 just to play a game, or they're just trying to make me mad or something like that. They really internalize and personalize 911 calls. That's what we mean by cynicism. Everybody's playing a game. Everybody's out to game the system. Everybody's out to get me. And we see that in people suffering from compassion fatigue. Another related condition is burnout. And we can probably all envision a firefighter that we would consider burnout. They are angry from the moment they show up to work until the moment they leave. Nothing is ever right. Anything you want to do, from eating lunch to going to train to actually taking calls, is an inconvenience. They walk in and they just suck the life and the air out of a room. We all know those people. And it can be contagious. That's one of the dangers of burnout is we can probably all envision firehouses, particularly in the career service, where you'll have 1 or 2 people who we would consider burnout. And over the course of a few months, we start to see that same attitude in the people that they work with. This burnout attitude can become chronic and it impacts those people around us. The issue, a lot of times people think that when they retire, they're going to leave that attitude behind, and they don't. It becomes chronic. It becomes ingrained in how the person thinks. So burnout can be a major, major issue. And on some level, burnout is very normal. I think we all experience it eventually we go on enough 2 a.m. calls where somebody is standing out front of their house with their suitcase packed, waiting for us to arrive. And that wears us down, and it starts to make us angry. Or getting disturbed from our supper because somebody has a toothache that's been going on for 3 weeks, and all of a sudden now they want to go to the emergency department for a toothache. Our frequent flyers, the people that we run on all the time, those things can wear us out, and that can lead to burnout. The way we combat things like compassion fatigue and burnout is through self-care. And we'll talk about self-care and how to do it, those 6 steps to improve it. But self-care is vital to building resilience so that when we're faced with these issues, we bend and we don't break. That's how I like to look at resilience, bending without breaking. Let's look a little bit more at sleep deprivation. It came up earlier. You see some common shift schedules. We don't see many 4896s in the Midwest. It's more of a West Coast thing. But we see a number of combinations of shift schedules. And this goes for volunteers too. Even though you may not be on a set shift, if you're working a full-time job and taking volunteer calls at night and on weekends, this can impact and you can suffer from sleep deprivation as well. One bad night of sleep will have an impact on us. So it's really important that we get sleep and we understand what's going on and why it's important that we get sleep. You see the sleep deprivation is tied to an impairment of extinction recall. It's a little complex, but extinction recall, if I understand it correctly, is basically our brain will process a traumatic event and recognize that, okay, this happened in our life. This is what we can learn from it, and we're safe now. and that we're safe now is a big part of extinction recall. If you don't have that, then your brain doesn't process the trauma, it doesn't know what to draw from it, and it may not ever feel safe as a result. So being able to sleep is tied directly to that extinction recall. And that's why people who are able to sleep after a traumatic exposure fare better. Trauma is processed while we sleep. I know one firefighter, Captain Dina Ali with the Raleigh Fire Department. She heads up North Carolina's peer support program. Every day when she gets off shift, she tries to take a 90-minute nap. Again, if you're a volunteer, that may not be possible. You may have your regular job to go to, but if you're on the career side, if you can come home and take a nap after your shift, that can help your brain process the trauma that you've been faced with beforehand. And you can encourage your crews to do that as well. And we can see the number. A lot of us suffer from sleep disorders. This is how sleep cycles work through the night. They're generally, if you get a full night's sleep, you'll go through 5 sleep cycles. They're about 90 minutes each. And if you look at this graphic, what you'll see is the dark gray. I'm colorblind. It may be green for all I know, but the darker gray or green colored box is REM sleep, and the orange box, or I'm sorry, the darker gray is deep sleep. The orange box is REM sleep. So what you can see happening during the night is when we first go to sleep, that first sleep cycle is a whole lot of stage 3 deep sleep and just a little tiny bit of REM sleep. And as the night goes on, that begins to reverse to where by sleep cycle 5, we basically have no stage 3 deep sleep, and half of it is now REM sleep. Our brain processes trauma during REM sleep. What ends up happening with firefighters, particularly when you're on shift, is you get woke up 2 or 3 times a night. So you're getting woke up every 2 hours. So you're just starting sleep cycle 2 and you get woke up. And then you go back to bed. Your brain does not pick back up in cycle 2 where it left off. It will start back at cycle 1. So you do that 3 or 4 times a night. You never reach cycle 5 where you're really getting a lot of REM sleep. As a result, your brain never gets the chance to process trauma the way it's supposed to. That's why it's so important that we try and get a straight 7 hours or 8 hours of sleep each night. On shift, that's just not possible. But that's why we start to see problems with things like PTSD, is because we're not getting REM sleep to process trauma the way we should be. We can see that not getting sleep also leads to a host of other problems. Cardiovascular disease, year in, year out, is one of the biggest killers of firefighters, and it is directly linked to lack of sleep. It's not just a correlation. There is actually causation that has been proved between lack of sleep and cardiovascular disease and high blood pressure. We see a lot of glucose and insulin tolerance in the fire service. That can also be directly linked to lack of sleep. And then we also know that there are behavioral health issues tied to lack of sleep. This is probably our #1 issue underlying so many other of our problems, including cancer. So addressing our sleep deprivation is huge. This sort of describes the PTSD issue that I described earlier about how we process that trauma during REM sleep. And if you don't get enough REM sleep, you don't process the trauma and you can end up symptomatic for PTSD. Something else that can happen here is because we're not getting enough sleep and we're having constant dumps of cortisol, and it's hard for us to sleep even when we get home. A lot of us go home, we try and sleep, and we're on edge even when we're off duty. So what's one of the things we can turn to help put us to sleep? And a common thing that we utilize is alcohol. Alcohol will make you go to sleep. Unfortunately, alcohol prevents REM sleep. So even though you're forcing yourself to go to sleep with alcohol, you're not going to get the REM sleep you need, so you're still not going to process the trauma. On top of that, alcohol also collapses the airways. It makes the muscles relax in the oral pharynx and the nasal pharynx, so you end up coughing and snorting and waking up because of breathing issues all night long. Alcohol also makes you pee, so you wake up through the night to go to the bathroom. So you're waking up several times through the night, even with alcohol. And then that can also, you keep trying it, you use that as your medication until you become dependent on it, and then you end up on the alcohol use disorder scale. So we can sort of see how all these themes are woven together between traumatic stress and sleep and underlying behavioral health problems and alcohol use. They're really inseparable on some level. So again, all of that plays together, and that's something to keep in mind with your crews. If you're in a department that will allow you to take naps, encourage your crews to take naps in the afternoon. That can be really helpful to try and get some sleep before, if you know you're going to be busy at night, get that sleep when you can. I know not all departments will allow napping during the day, and I respect that. But if you do have that option, I encourage you, and I encourage you to let your crews know that that's a good thing to do, to try and get some extra sleep. We're going to talk a little bit about suicide here. We know firefighter suicide is an issue. There's all different debates about suicide rates and you know, comparing us to the general population and to ourselves and all that. I'm not here to discuss the stats on it. Are firefighters dying by suicide? Yes, that's all I need to know. We're dying and we shouldn't be. So what do we do about that? What to do and who to call? If you believe that a coworker is suicidal, the best thing on earth you can do is to ask them about it, and ask them about it very directly. And it should start with one question. Are you thinking about killing yourself? If you get a yes or a maybe, because keep in mind that maybe equals yes when we're talking about suicide. If that person says yes, or yeah, maybe I've been thinking about it, we need to ask some follow-up questions like, do you have a plan? Have you taken any steps towards completing the plan? Have you attempted suicide before? The reason we're asking those follow-up questions is we want to determine how immediate the threat is. Someone who says, I've thought about killing myself, but I don't know how I would do it, is a much different scenario than somebody who says, yep, I've thought about it and I have the gun in my locker. Those are much different scenarios. One is a lot more immediate than the other. So that's why we want to ask those follow-up questions. But at the very least, asking directly about, are you thinking about killing yourself, is vital. Don't ask, are you thinking about harming yourself? Don't ask, are you thinking about hurting yourself? Those are the wrong questions. We want to ask, are you thinking about killing yourself? Some people may be afraid that, well, what if they're teetering close to the edge? If I bring up suicide, can I put the idea in their head? Can I push them over the edge by bringing it up? And the answer is no. This has been studied. You're not going to put the idea in anyone's head. I guarantee you that every one of you who sat down for this webinar today knew that suicide existed. Bringing it up is not going to be some revelation to anyone. So asking directly about suicide and not being afraid to ask is key. So why do we avoid asking? Because we know we do avoid it. We ask patients all the time if they were trying to kill themselves and we don't think anything about it. But we won't ask each other that question. My opinion is the big reason that we don't ask is because we're afraid they're going to say yes. And then what? What do I do if they say yes? Here are some answers. If it's an immediate threat, if this is, I think this person is going to try and kill themselves now or in the immediate future, call 911. We don't want to do it. I get that. But in my role with Indianapolis, I have had to call 911 on one of our members, and it saved that person's life. The police showed up. The individual was in a vehicle in a parking lot with a pistol in his lap, drunk. And the police were able to talk to him. They de-escalated things, got the firearm away from him, and we got that person help. Had I not called 911, you know, I obviously don't know what would have happened, but my inclination is that that person was ready to pull the trigger that day. Everything indicated that they were. So call 911 if you need to. If you're with somebody, it's not an immediate threat and they have a therapist, you can call their therapist. That's fine. In fact, that's encouraged. It's not an immediate threat. Call, leave a message, and the therapist will give them a call back and they can talk to them. If they don't have a therapist or it's after hours, call the National Suicide Prevention Lifeline. That number is 800-273-8255. If that number is not in your phone, it needs to be in your phone by the end of this discussion. Every fire officer, every firefighter should have that number in their phone. It's useful for us. It's useful for if we're on the scene with somebody, but that number should be in your phone 24 hours a day, 7 days a week. If you call that number, you will get a person who is trained in suicide intervention who will talk to you and will talk to the firefighter about what to do next to keep that person safe. And it's not limited to suicide. Anybody in a mental health crisis can call that number for assistance. They have suicide in the name, but it's not limited just to suicide. So that's another option. If you're with a firefighter and they're having panic attacks on station and you're not real sure what to do, you can call that number as well, and they'll help give you some guidance. You can also text 741-741, and it doesn't matter. I have Connect, but you can text home, help, what's going on. You can text anything to 741-741, and somebody from the Suicide Prevention Lifeline will text back. So there's a texting option for people who don't want to talk. Separating the person from the lethal means, let's say the person discloses that they intend to die by suicide and they want to shoot themselves. Separating them from their ammunition, separating them from their guns in the short term is vital. If we can prevent a suicide in the short term, we can normally prevent suicide in the long term. So getting them separated from that lethal means is really valuable. There's training called Counseling on Access to Lethal Means. It's online for free. If you just do an internet search for CALM training or Counseling on Access to Lethal Means training, it's offered by the Suicide Prevention Resource Center, and it teaches you how to have that conversation with somebody about how are we going to separate you from the means you want to use to kill yourself. Our team members on our peer support team take that training every year as continuing education. Again, it's free, it's online. Do it at your own pace. It doesn't take very long, just a couple hours, but it's really great training. And this is also, if you have a peer support team, a great time to reach out to them. If we show up, if you were in Indianapolis and you were with somebody who noted that they would like to die by suicide and you reach out to us, we'll send a peer out to your location. And once we show up, you can leave. That's what we do. We can take it from there. So if you have a peer support program, this is a great time to involve them. Because again, since we don't want to leave the member alone, it may be hours before you're in a position to leave that person. So peer support can take over and they can sit with the person during that time until it's determined that they're safe to leave. Let's look at self-care a little bit to kind of wind things up here. 6 things that we can be doing for our own mental wellness. The first thing is perform well-being examinations. And this goes for you and for your crew. Ask yourself, have I been more angry than usual? Has my crew been angrier than usual? Has somebody really stood out to me that they've had a change in attitude or a change in behavior that I've noticed? And if you have, there's probably something to discuss with that person or to think about yourself. You can also do an internet search for compassion fatigue tests. They're a great resource to kind of give you an idea of how much secondary trauma somebody has been exposed to. And they're free, they're online, they're really good tests. I encourage you to take them as an officer. And if it's something you think your crew would do, to encourage your crew to take them too. I know that can be a tougher sell, but at least for yourself, it's a really good thing to kind of figure out where you fall as far as vicarious trauma is concerned. The next big thing is spending time with loved ones. A lot of times we're under the impression that just because we're inside the same structure as another person, that means that we're spending time together. But we all know that we can be sitting in chairs right next to our partner or our children, and we may as well be 1,000 miles apart. So actively making time to do things together that make you laugh, that make you smile is very important. Not overly isolating yourself. We have a real bad habit about our family is in one part of the house and we go out to the garage or we go up to our den or we watch TV and we basically have walls around us to wall us off from people so we don't have to make decisions. I think it's a good thing if you need a transition period when you first get home to make the transition from firefighter to partner. That's great. Talk to your spouse or your boyfriend, your girlfriend about it and say, I need 20 minutes or an hour when I get home from shift to just be left alone. And then once that time is up, I'm all yours. But I need to transition because I'm going from a very hectic, very high intensity environment to one that isn't that way. And I need to transition out of it to get ready. I think that's great. The key is communication. And if you're having problem with the call, let your partner know. We think that we can compartmentalize our work life from our home life. And I'm here to tell you, we just can't do that. It all goes into the same brain, right? The things that happen on the job go into the same person. So that same person goes home. Everything that happened at work is going with you. So really trying to compartmentalize that is difficult, if not impossible. And the people at home know when we're struggling. If we're upfront with them and just say, I had a really bad kid call, I don't really want to discuss it, but keep an eye on me because I might be struggling a little bit. If you notice I'm getting angry, let me know because that's something that I need to keep track of. But just be honest and let them know when something's going on. Next, if you have support services, use them. Every June 4th, that's my hire date. Every June 4th, I call our employee assistance program and I make an appointment once a year. I figure I go once a year to get a physical. For the rest of my body, I need to go once a year to talk to a behavioral health professional about my mind and my brain and my psychological health. If you have an employee assistance program, somebody's already paid for those visits, I encourage you to use them. At the very least, make an appointment with your physician and do the same thing. And just, say, just want to get a mental health check. They have some screens that they can do, pretty routine, and talk to them about it. There are a couple of really good reasons for this. One, they may catch something that you don't think is wrong. We see this on the medical side all the time. I went to my physical last year, thought I was in great health, everything was perfect, and my cholesterol was through the roof. I would have never have known that. I thought I was perfectly healthy, but it took somebody who knew what they were doing to pick up on that and tell me that there was a problem. Same thing is true with our brains and our minds. Our brain is a lot more complicated than any other organ in the body. So going in once a year, you may not think that there's anything wrong, but making that appointment, having that visit, somebody who knows what they're doing may pick up on things that you don't see. Also, it teaches you how the process works so that if you eventually do find yourself in a crisis, it's going to be a lot easier to reach out and make that call to get help, because you're going to have a rapport established with the behavioral health professional. You're going to know how the system works. You're not going to be left scrambling when you're struggling to try and figure out how to get help. Next, establish a life beyond this job. Firefighting consumes our identity. And the problem is, no matter how good you are at this job, the day is going to come when you're no longer a firefighter, when you turn in your helmet and your boots, and then what? Start planning for that now. Find hobbies that you enjoy so that when you retire, you can have a purpose. A purpose-driven life lets you live longer. If you don't have a purpose, we tend to retire, we stagnate, and we die. That's the sad reality. So find those hobbies now so that you can enjoy your retirement and live out your life with purpose. But just being consumed by the fire service is not going to give you that fulfillment after you retire. Make non-fire friends. What do we always end up discussing when we get together in a group with other firefighters? The answer is we always end up discussing firefighting. And usually pretty early on, we go negative and we start criticizing people or bad-mouthing people. And there's some real value in that. It's really important that we have firefighter friends who understand who we are, how we think, who aren't going to be offended by the incredible things that we say that would completely offend most other segments of the population. We don't take that stuff personally, we get it. So it's important to have that outlet, but that shouldn't be your only outlet. We need to have a broader expanse. If for no other reason that when we retire, we need to have friends to connect with. We tend to think that I'll retire and I'll keep going to the firehouse and having coffee, and those relationships will still exist. But unfortunately, people promote. People bid out of stations. That station that you love so much today, in 2 years, none of those people may be there. So keep that in mind, that the fire service is always changing. So having friends outside of the fire service is vital. And then the sixth point is to try something new. I'm a big advocate of meditation. I first started meditating because I wanted to prove it wrong. That's the kind of person I am. I was like, it's not going to work for me. I won't be able to sit still. I won't be able to quiet my mind. I'm going to lose my edge. All the stuff that you're probably thinking if you don't meditate now. I found out that's not how meditation works. I used a website called mindfulnessexercises.com. They had a 28-day challenge. And I said, I'm going to faithfully execute this 28-day challenge to prove that meditation won't work for me. And it did. It actually ended up working. And it changed my perspective. It made me sharper. I don't react now, I respond. That period between stimulus and your response, meditation lets you own that so that you're just not reacting, because reactions can be really poor decisions. But it gives me a chance to stop, think, and respond. So I highly encourage you to look up meditation. There's some great apps out there, but if nothing else, that mindfulnessexercises.com, do the 28-day challenge. Yoga is another great thing. It's not something I ever thought I would be involved with, but after I saw meditation worked, I knew meditation and yoga practice kind of went hand in hand. So I started doing that, and now I'm a yoga teacher. Again, I was never like that crunchy granola guy, believe me, but this stuff works. It's thousands of years old. If you want to meditate, but you just don't think you can sit still for it, you can do mindfulness walking, where you're actually moving and meditating at the same time. And again, this is something that you can do an internet search for, particularly on YouTube. Put up guided mindfulness walk, and you'll get a YouTube video that will take you the whole way through a mindfulness walk of any length that you want. And then finally, combat sports. Jiu-jitsu in particular, I practice jiu-jitsu. The human body needs contact. We don't get a lot of it. We don't get a lot of physical contact, particularly men. Combat sports are a way to get that, where you wrestle or grapple or fight under controlled circumstances. You can work out some aggression. You get the benefits of cardiovascular exercise and resistance training. And it's also very mindful. When you are sparring with someone, you're not thinking about yesterday or tomorrow. You are 100% in the moment. And that has all of its own benefits. So try something from that list. Give it a shot. Something that you may not otherwise try, but try it out and see how it works for you. I'm proof that things that I didn't think would work for me absolutely did. Two books that I would recommend. One is Emotional Survival for Law Enforcement. As an officer, this is a great book for you to have. It helps you understand the biological roller coaster that we go on from work to going home, and why we want to sit in a recliner and just flip through channels and not answer any questions and not make any decisions. Understanding that is really valuable, and being able to relate that to your crews is also really useful. The other book, Resilience, looks at 10 areas that people who are resilient thrive in. The authors looked at prisoners of war. They looked at survivors of the Holocaust. They looked at trauma survivors, and they also looked at elite military personnel. And what is it about those four groups that allows them to be so resilient? And they drew 10 areas, and that's what that book is about. It actually also serves as the basis for the IAFS new resiliency training that's going to be coming out. So neither book is very thick. They're easy reads. They're written in layman's terms. I would recommend anybody in the fire service, particularly fire officers, read both of those books to get a better understanding of how they can relate to themselves and their crews to improve behavioral health. This is my information. Please, if you have questions or concerns, or if the alcohol use disorder part particularly hit home for you, reach out to me. That's my personal cell phone, not the city's phone. That's my cell phone. Give me a call or a text. We'll keep it private, and I'll see what I can do to help you out. So any questions or anything, please let me know. I don't know if we have time for any questions or how that's all set up, but that is my presentation. Thank you, everybody.
We do have time for questions. If anybody has any, you can ask them. I'm not seeing anything coming through.
Okay. I certainly appreciate the opportunity to come and talk to everybody on this topic. It really means a lot. Thank you for having me.
Yeah, sure. We do have just one question here. What do you do for the employee that will just not accept help?
Well, generally speaking, there's not anything you can do. If that person is unfit for duty, we have a process where we would cycle them through, provide documentation on why we think the person is unfit. Usually it's for safety issues, and we would run them through our medical unit, and then they would determine whether or not that person could work. If they were found unfit, then they would have to do certain things before they could come back to work, and they would have to get cleared by that unit. The best thing is to give people time. It took me years before I finally got help. And people told me a lot that I needed to get help, and I just wasn't going to listen to it. So if they absolutely refuse, it's just like any other medical condition, they're free to refuse. But if it becomes a safety issue, then I think you have to take, as an officer, take those steps necessary to make sure that you're safe and your crew's safe, because your crew's safety is your primary responsibility. And if somebody's going to jeopardize that, you have to take the steps to keep them safe. Otherwise, just be patient and keep trying, honestly.
Okay. And then I have another one that's, what is your level of training for mental health?
I have taken some, as far as the addiction side, I'm certified by the state of Indiana as an addiction peer recovery coach, a community health worker, and a certified recovery specialist with a substance abuse endorsement. I've taken the IFS 2-day online peer support training, 2-day in-person peer support training. I'm also a master instructor for the IAFF peer support program. Those are my main backgrounds. I've taken Safe Talk. I'm a Safe Talk instructor. It's a suicide prevention program. Applied suicide intervention skills training is another program offered through Living Works that I'm certified in. Those are probably the main things for suicide prevention and peer support. I'm not a clinician on any level. I'm a peer like any other firefighter who works in peer support.
All right, and that is all that I see. So Thank you so much for joining us today, everybody, and thank you, Captain Dreiman.
Thank you. I appreciate it.